The next topic we're going to cover is infants of diabetic mothers. We've had a little bit of this when we were in the complications of pregnancy, and really you all did a case study on this too, so we're going to hit the high points and move along. Pathophysiology, so hyperinsulinemia, or increased amounts of glucose cross the placenta and stimulate the fetal pancreas to release insulin. There are a lot of congenital anomalies around infants of diabetic mothers. The incidence of congenital anomalies among mothers with pregestational diabetes is 2 to 5 times that of pregnant women who do not have diabetes. The most common involve the cardiac, renal, musculoskeletal, and central nervous system. The incidence of congenital heart defects is 2 to 3 times higher for infants of diabetic mothers in the general population. This picture shows an infant of a diabetic mother. It's an LGA baby, and he weighs 11 pounds, so he's a whopper. Macrosomia is a complication of infants of diabetic mothers, and this with macrosomic infants, they have excessive shoulder size, and they often lead to a shoulder dystocia and a difficult birth. Therefore, they experience birth trauma and perinatal hypoxia, which occurs more often in infants of mothers with diabetes. They are also at risk for respiratory distress syndrome, so maternal hyperglycemia can affect the fetal lung maturity. LGA babies have a round face, a chubby body, and a flushed complexion, enlarged internal organs, and increased body fat, and this is especially around the shoulders, which results in the birth trauma. Glucose does not cross the placenta, so the brain is the only organ not affected. They are at risk for neonatal complications of hypoglycemia, hypocalcemia, hyperviscosity, and hyperbilirubinemia. With the respiratory distress syndrome, the synthesis of surfactant, and remember surfactant is what preterm babies lack and what term babies have that assist with breathing. So the synthesis of surfactant in infants of diabetic mothers, or IDM babies, that can be delayed. So RDS is 6 times higher when the glucose is not controlled. Hypoglycemia is defined as blood glucose levels less than 40 in term infants. Signs and symptoms include jitteriness, apnea, tachypnea, and cyanosis. LGA and preterm infants have the highest risk. And how do babies end up hypoglycemic? In utero, neonatal hyperinsulinemia, so the baby produces extra insulin from the high levels of maternal glucose levels. When the cord is cut, the glucose supply is cut off. The infant continues to produce those high levels of insulin, and that causes hypoglycemia because the glucose that was coming across to the baby in their bloodstream, that's cut off, so they no longer have that continuous influx of glucose. Typically treated with IV glucose in the NICU, and I know several of you all have seen IDM babies and hypoglycemic babies in the NICU. They are also at risk for hypocalcemia and hypomagnesemia. These are not usually present until 48 to 72 hours after birth. Jitteriness is a sign of hypocalcemia, hypomagnesemia, and hypoglycemia. So what you have to do is rule out hypoglycemia and then move on to the other electrolytes, since the jitteriness is a symptom of all of them. IDM babies are also at risk for cardiac defects, and we talked about that. So cardiomyopathy is a disease affecting the structure and the function of the heart. They can be hypertrophic, which is hypercontractile, and a thickened myocardium, and this can result in outflow tract obstruction. So the baby, when the heart pumps, the blood don't flow out like it's supposed to. And there can be non-hypertrophic, which the myocardium is poorly contractile and overstretched. They have large ventricles and there's no outflow obstruction found. So with the non-hypertrophic, the muscle does not work how it's supposed to. Hyperbilirubinemia and polycythemia is an increased number of red blood cells to be hemolyzed, increases the potential for bilirubin load that the neonate must clear, thus increasing the likelihood of hyperbilirubinemia. So infants of diabetic mothers have more red blood cells to break down. We know those red blood cells break down into hemoglobin, and eventually the excess of the heme that's broke down cannot be excreted by the baby, and so they end up jaundiced. Nursing interventions for IBM babies. Infants that require intervention include birth trauma, perinatal asphyxia, RDS, difficult metabolic transition, including hypoglycemia, hypocalcemia, and congenital anomalies. Okay, next we're going to talk about neonatal infections. And I took a lot of notes on the neonatal infections. So you're going to have these to be able to print, but I will also go over them for those that do better when you hear it. But you'll definitely want to study your notes well. So the first neonatal infection we're going to talk about is sepsis. Sepsis is the presence of microorganisms or their toxins in the blood and other tissues. The newborn infant is susceptible to infection because of their immature immune system. If you look on table 35-2, which is on page 858 in your book, it goes over the risk factors for neonatal sepsis. Prenatal infection is often caused by organisms that are transferred from the placenta to fetal circulation, or there can be infected amniotic fluid. Some of those examples are herpes simplex virus, cytomegalovirus, or rubella. Sepsis can result from an ascending vaginal infection, so going up the vaginal canal. That can cause membranes to rupture, resulting in infection of the fetal skin, respiratory tract, or the GI tract. They can also contract sepsis when they are in the birth canal. When they are in the birth canal, they can contract the organisms, and that can result in generalized sepsis or local infections. For instance, generalized sepsis would be sepsis of the blood, obviously, and a local infection could be one of your STIs or infection in the eyes. There's different ones. Early onset sepsis, so there's an early onset and a late onset. Early onset sepsis appears within 24 to 72 hours after birth. It progresses more rapidly than late onset, has a fairly high mortality rate from 2 to 40%, usually caused by organisms from the normal flora of the vaginal tract. So it's just normal flora, but the babies can't tolerate it. Early onset sepsis is associated with preterm labor, PROM, maternal fever during labor, chorioamnionitis, and the organisms include group B strep, H. influenzae, Listeria, E. coli, and Strep pneumoniae. Late onset sepsis occurs from 7 to 30 days of age, can include maternally derived infection or healthcare acquired. So late onset sepsis could be, just caregivers' lack of washing their hands or maternal lack of washing their hands after you go home, or it just takes that long for the baby to get infected and show signs and symptoms. Or organisms include Staphylococci, Klebsiella, Enterococci, E. coli, Pseudomonas, and yeast. Additional infections of concern include MRSA, VRE, and MDROs, and those are all organisms that are resistant to antibiotics. Entry can occur at the umbilical stump, through the skin, mucous membranes of the eyes, nose, pharynx, or ear, and internal organs such as the respiratory, nervous, urinary, or GI system. So, multiple entry points. Other infections include viral infections that can be acquired prenatally, can cause stillbirth, intrauterine infection. Fungal infections are great concern in immunocompromised or premature infant. Septicemia refers to generalized infection of the bloodstream. Pneumonia is the leading cause of perinatal death. And septic shock results from toxins released in the blood. So signs and symptoms of septic shock include decreased blood pressure. The baby actually turns gray, like just they have no color. They turn gray and they're mottled looking. They have cool extremities and an abnormal breathing pattern. Assessment includes the earliest clinical signs are very nonspecific and include lethargy, poor feeding, poor weight gain, and irritability. So I've always said, and my preceptor taught me, that newborn nurses and mother-baby nurses have better assessment skills than NICU nurses, because once the baby is in the NICU, we know it's sick. It's hooked up to a monitor, we're doing lab work, we know it's sick. It's the newborn nurse or the couplet care nurse that their assessment skills have to be just spot on to notice just a slight difference in the baby before they get sick. And you also want to always pay attention to the mom. If she says, my baby's just not acting right, something's just not right, you better pay attention to them. And so the parent or nurse note that they're just not doing as well before. Differential diagnoses include hypoglycemia or anemia. If you look at table 35-3 on page 859, it shows you the signs and symptoms of infection. Lab specimens include blood, CSF, and urine, and these babies always get a CBC. Interventions include antepartum and neonatal treatment of viral infections and antiviral medications. So moms can get antibiotics or antivirals during labor, and those drugs do get to the baby, cross the placenta, so we can start treatment actually during labor. Treatment so that would be if you know they're sick and in labor, but if it's been a well baby and you think something's just not right and we're going to go ahead and get lab work on the baby, you wouldn't start your antivirals or antibiotics until after their blood cultures because you wouldn't want to contaminate it. Breastfeeding is also considered an intervention. Different types of medications we talked about. Your book noted to suction these babies only if necessary. So if you see a bunch of secretions, would you suction? And these babies need to be put in isolation. Preventative measures include hand washing, standard precautions, and the antibiotics that are put in all babies' eyes when they're born.